Hello everyone. So in this video we will discuss the lab values, and in lab values we will have our blood profile. So our blood profile, then we will have our electrolyte profiles. Also we will discuss about the blood cells origin. Okay, so before hematology you need to know this, and then we will have our beautiful liver, our LFT, liver function test, very important for all the clinical life of our. Then we will have our urine analysis or urine test. Okay, so this is a very important video for all the exams and our clinical life. Okay, so we start with the mother cell in hematology, that is the hematopoietic stem cell. We all know that stem cell are the origin of every type of cells in the body. So this is a hematopoietic stem cells, and as we know, all the blood components origin from here. So next we get first generation cells. There are two type of first generation cells, the progenitor cells. First one here is the common myeloid, and second one is common lymphoid. So two types of progenitors. So the blue one here, and let me change this, the red one. Okay, fine. So the blue one and the red one, we can differentiate it, and the red one is common myeloid progenitor, and the blue one is common lymphoid progenitor. Fine. Then let's divide further. So from the common myeloid progenitor you get all the maximum type of cells in the body. So you can see here the red one, you can suspect it as RBC, right? So the first one is proerythroblast, then reticulocytes, and then RBC. So this is how RBC forms. Okay. Now next one, from the same common myeloid progenitor. Okay. Then this is the bigger one, and then it is our megakaryocyte, and then from that we get our platelets. Okay, next one, and a chunk of cells develop from this. Okay, so as you can see, these things are important to know the cell structure and cell origin. Okay, this is a very important chart in hematology. So here we get our monocyte and then our macrophage, the guy who is responsible for all the bacteriophages for your immunity in your body. Okay, so this one is monocyte, and then macrophage. Okay, Then you have three sister cells, which we called, let's draw it first, the neutrophil, basophil and eosinophil. Okay, you need to know the structure of these three cells. Okay, you need to remember, because in FMG they give the cell slide and they will ask you which type of cell is this. Okay, so in you can see the nucleus. Okay, you can differentiate it by the nucleus structure. Okay, so first one, as you can see, we have a pinky cytoplasm outside. Let's draw it first. Okay, and a deep nucleus. So this one is basophil, which is a little nucleus, then neutrophil, which have segmented nucleus, and then you can see it's like headphone. Okay, so it's eosinophil. You can remember like this. Just you need to remember the nucleus of these three cells. They can give you slide in FMG. So it's important for CROC and FMG too. Now come to the common lymphoid progenitor cells. So here we get the lymphocytes, and as you know there are three types: the B cell, T cell and NK cells. So here we get our B cells, then T cells, then our NK cells. So these guys also for our immunity. Okay, B cell, T cell and then natural killer cells. And let's write down our name. That is our myeloblast, and this is our megakaryoblast, then megakaryocyte. Okay, then it is our lymphoblast. Okay, these three, eosinophil, basophil and neutrophil, are called granulocytes, and monocyte and lymphocyte are agranulocytes. Okay, remember these things. Then from the macrophage till the B cells, T cells and NK cells, you already saw the myoblast and the lymphoblast. These are together called WBC, our white blood cells. So white blood cells contains these 1, 2, 3, 4, 5, 6, 7 types. Let's come to the blood profile, which is a very important chart for the exams. Just remember the normal range and the increased condition and the decreased condition. So first one is RBC. Range is 4.5 to 6.6, you can say. It's for male. Okay, it's million per, so male. For female -1. Okay, so 3.5 to 5. Then as you can see, the increased condition, in which condition happens when the RBC get increased or get decreased. So if the RBC cell count get increased, so first one decrease. If it is less than 4, it's called anemia. Okay, correlate with hemoglobin and also. So if it is more than 6.5, it's called polycythemia vera. Okay, then next one in our list is hemoglobin. You need to remember this chart by heart. Okay, every exam in your clinical it will need it. It's 13 to 18 gram per deciliter. Okay, and if also hemoglobin decreases, it's called anemia. So less than 12, we call it anemia. 13 to 18, it's average. 14 to 16 male and 14 to 18 male and 13 to 17 female. Too much, if we get hemoglobin, we can suspect for blood cancer. Okay, then third one in our list is or hematocrit. uh, it's important parameter, but not much like RBC and hemoglobin. Anemia we can get through RBC and hemoglobin also. So 45 to 55% its hematocrit is normal. Then we write down the RBC things in this column and the WBC on the next column. Okay, so MCV, mean corpuscular volume, 78 to 98, its normal range. It get increase, so it is the average size of your RBC. Okay, so we get, if it is increase, we get a megaloblastic anemia. We call the condition megaloblastic anemia. So MCV increase in megaloblastic anemia and MCV decrease in microcytic anemia. Megaloblastic anemia occurs due to deficiency of B12, folic acid, and microcytic due to iron. So you need to know the anemia things also. I will do a separate video for that. So it average RBC size. Okay, there are three parameters: MCV, MCH, and MCHC. Okay, these can differentiate the type of anemia, megaloblastic or microcytic. Then next one is MCH, mean corpuscular hemoglobin. It's 27 to 35 pg. It get increased in again megaloblastic or macrocytic anemia. So its average hemoglobin in each RBC, it get increased in it's not macrocytic anemia and get decreased in microcytic. So megaloblastic and microcytic are this terminology is used interchangeably. There is a little difference. And the third one is MCHC. So it's the average hemoglobin in per volume of RBC. Okay, for volume of blood, it's 31 to 33 percentage. Same increase in macrocytic and decrease in microcytic. The seventh one is color index. So it's the color of your RBC. Okay, the normal range is 0.8 to 1.1. If it is get increased, we get hyperchromic anemia, which also you can see in macrocytic anemia, which is B12 and F9. Sorry, folic B12 and B9 folic acid. And decreased hypochromic anemia. Hypochromic anemia you can see in iron deficiency anemia. Okay, so our IBC part is done here. Now in the next section we will discuss the WBC one. WBC, you all have read the origin of the cells. Okay, now WBC. So WBC range is 4.5 to 10 or 11, you can say average. It is mentioned in 10 to the power 9. So if leukocyte increases, the condition is called leukocytosis. So if leukocytosis occurs in the range of 20 to 30,000 into 10 to the power 9, we suspect acute bacterial infection, mainly acute infection which is bacterial mainly. And if it gets more than 100 into 10 to the power 9, we suspect leukemia. So lymphocytosis can be acute infection, can be leukemia, depending on the cell count. Then if get decrease, we suspect this is called leukopenia. Okay, if get decrease less than 4, we call it leukopenia. So increase leukocytosis, decrease leukopenia. So we get decrease in some viral fevers, in radiation. Then in bone marrow suppression diseases like aplastic anemia, myelofibrosis, like this. Okay, so now we'll discuss the WBC components we have studied earlier. So here we have our neutrophils. The range is 50 to 80%, and same as WBC. So neutrophil increase neutrocytosis and decrease neutropenia, the same conditions as WBC. Okay, because these are the components of WBC. Okay, then you have our eosinophil, which is normal range 1 to 5%. If it gets increased, it get increased in the same condition as WBC, also in allergic reaction. So in allergic reaction we get high eosinophil, more than 6. Then basophils, the normal range is 0 to 1%. If it get increased, same as WBC, and also in burn patient we get increase. Also in hyperthyroidism the basophil get increase. Then in rheumatoid arthritis too, basophil get increase. Cancer also. Okay, then we left with two, the monocytes and lymphocytes. So here is our lymphocyte. (15 to 45%). So you know the leukemia, we have two type of myeloid leukemia and lymphoid leukemia. So if lymphocyte predominant leukemia, it is called lymphoid leukemia, and the monoblast leukemia, it's called myeloid leukemia. So you can see in cancers. Okay, and they decrease in same conditions like viral fever or something else. Okay, then we have the thrombocytes, which will call our platelets. It is responsible for your blood clotting. So if the normal range is 1.5 to 4.5 lakhs, in India it's 1 to 3 or 4, you can say. Okay, so what happen if it get increase or decrease thrombocytes? Okay, so thrombocytosis and thrombocytopenia. So thrombocytopenia occurs in ITP, idiopathic thrombocytic purpura, in dengue. Okay, in hemorrhagic uremic syndrome, in DIC syndrome. These syndromes causes thrombocytes to decrease. So these are the bleeding disorders. Okay, bleeding tendency disorders. Okay, then so polycythemia vera, it increased thrombocyte. Cancer, we get increased thrombocytes. Okay, the next one is our basal metabolic panel, or you can say the electrolyte panel. Okay, so these charts are very important in your daily life when you will do clinical and also in exams. So first one is our sodium Na. The normal parameters is 135 to 145 milliequivalent per liter. So increase means hypernatremia and decrease mean hyponatremia. So I am discussing these things in short here. We'll do a separate video on hypernatremia versus hyponatremia versus hypokalemia. We'll do details there. Okay, so here just the conditions where hypernatremia can be seen. So if you increase intake sodium, so hypernatremia will occur. If the aldosterone in your body get increased, okay, sodium will increase in blood too. Sodium retention will occur. Then if Cushing syndrome occurs, in Cushing syndrome also sodium retention. Then in diabetes insipidus also sodium retention. Actually more than sodium retention it's water excretion, so you will get hyponatremia there. So hyponatremia, either excess water excretion without sodium or sodium intake increase. So hyponatremia, here you can have, like if you have severe vomiting or diarrhea, water and sodium gets excreted from your body, okay, you will have dehydration plus hyponatremia. Okay, there are different types: isovolemic, hypervolemic, hypovolemic. We will discuss this later. In diuretics use, you will get hyponatremia because sodium excretion, decreased intake of sodium, and in syndrome of inappropriate antidiuretic hormone release. Okay, SIADA syndrome, you get hyponatremia. Okay, again in details we'll discuss later. Okay, so next one is our potassium. So these are the two most uh, important electrolyte in our body and get disturbed very quickly with lots of things. So potassium, the normal range is 3.5 to 5 milliequivalent per liter. Okay, again hyperkalemia and hypokalemia. And hypokalemia. Okay, so what condition we get hyperkalemia? We can get hyperkalemia. First one is, as you know, decreased potassium excretion from body. So what causes? First one is, in case of renal failure, if renal failure occurs, you can't excrete the potassium, so hyperkalemia will occur. Then with aldosterone, decreased potassium excretion, so potassium retention occur with aldosterone. Then with ACI inhibitor drugs like ramipril, captopril, okay, they do potassium excretion, decrease potassium, they do decrease potassium excretion. So sorry, aldosterone antagonist. Okay, and then adrenal insufficiency too. So renal failure, aldosterone antagonist, ACI drugs, adrenal insufficiency. Increased intake can result in hyperkalemia. Then beta blocker can result in hyperkalemia, but these are rare side effects of beta blocker. Beta blocker are pretty much safe drugs. Then in acidosis, so metabolic acidosis will cause less potassium excretion, and low insulin will cause less potassium intake of the cells. So increased potassium excretion can cause hypokalemia. The causes can be diuretics. So for diuretics I will do a separate video. Hyperaldosteronism can cause increased potassium excretion, decreased intake. Then high insulin insulin actually resorbs the potassium into your cardiac muscle, skeletal muscle, adipose tissue. Okay, with some channels called GLUT4. So we'll discuss these things later. It's important for your FMGE exams later. Okay, FMGE, NEET, PG, it's very important. And alkalosis also cause hypokalemia. Next one is creatinine. It's very much pretty much used in daily life. Okay, so the normal range is 0.6 to 1.2. Actually it shows that how your kidney is functioning. Okay, if it is increased in your body, there is kidney in blood, there is kidney problem. And for CT scan, for MRI, so any of you, if you using dye, you need to check the creatinine. Okay, so if it is more than 1.6, then you cannot do any investigation which includes dye. So like CT coronary angiography, then MRI with dye, you cannot do this test. Then fourth one is cardiuria nitrogen, same as it is also used for kidney function. So if it get increased in your body, you know that there is some problem in your kidney. Okay. So these are some simple things which you remember. You will get tremendous benefits in your clinical life also. Then you have calcium, again important thing, 8.5 to 10.5. So there is two again, hypercalcemia and hypocalcemia. When we talk about the nephron function and diuretics, okay, in that video you will get clear about these things, like in which condition which diuretics you will get hypernatremia, hyponatremia, hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia. So okay, these electrolytes are pretty much dependent on your kidney function. Okay, and when they are getting excreted or getting reabsorbed. So these are pretty important things we will discuss in a separate video. For today, this is just a chart you need to remember. Okay, same, if intake increases, then if you have hyperparathyroidism, so parathyroid gland, what they do calcium excretion from the bones. Okay, then thiazide diuretics, they what do, they do calcium reabsorption. Then bone tumors, calcium will get excreted from the bone. Okay, then hypophosphatemia too. So if you have less phosphate, more calcium will come to blood and your bone get weakened. So decrease intake, decrease vitamin D. Vitamin D and calcium are interlinked. Okay, if one get decreased, the other will get decreased too. Then hypoparathyroid, so if your parathyroid gland is less functioning, you will get less calcium in blood. So this parathyroid hormone also works on nephron to reabsorb your calcium. Then hypoalbumin, calcium binds with albumin. So if you have less albumin, you will get less bind calcium. Okay. Then again, so hypophosphatemia, hypercalcemia, hyperphosphatemia, hypocalcemia. So it is indirectly inverse. Inversely proportional. Okay, these two things. So the next one, I think the both side chart was a good better. Next one will be that. So next one is glucose, 70 to 100, it's fasting one. Okay, pp is different. So we let's start read fasting first. So if get increase, we know it's diabetes, you all know that. So more than 110 in fasting, we suspect it's diabetes mellitus. Then chloride, not pretty much used in daily clinical life, but for exams it is needed 95 to 105. Okay, and there is one disease, cystic fibrosis, where these parameters will be needed for chloride. So here potassium, calcium, sodium and glucose are the most important things in this chart. Okay, bicarbonate is 23 to 29. So if we get increased bicarbonate, we get metabolic alkalosis, and if we get decreased, we get metabolic acidosis. So metabolic alkalosis, metabolic acidosis, we will have separate video, important topic also. So from these things, if you need any separate video of anything in details, okay, you just put a comment. So metabolic acidosis, if we get decrease. So we will have metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis in a separate video. Okay, acid-base disorders, pretty much important for every exam. So here from the 7, you know, sodium, potassium, calcium and glucose are the most important things. Also the bicarbonate. Okay, so next one. So next one is our liver function test, our detoxifier, and we need to know what happens when there is some enzyme irregularities in our body. So first one is AST, it's aspartate amino transferase. And then we have to know the normal range. So second was okay, so aspartate aminotransferase, also known as, we need to know that also, because in some countries or some lab values you will get SGOT. Okay, so you need to know that also. So AST or SGOT normal value is 9 to 40 unit per liter. Then you have ALT, it is alanine aminotransferase, and its name is SGPT. So these enzymes, like if you see any irregularities, you can suspect there is some problem in liver or in some other tissues, because ALT, it is a very pretty much liver specific ALT, and AST, it's in liver and also in some tissues also. So ALT 7 to 60, and it is liver specific enzyme. This is our beautiful liver and liver specific. Okay. Then number 3 you have bilirubin. As we know, we have total bilirubin value, conjugated and conjugated, or you can say direct and indirect bilirubin values. You need to know all three parameters here, because different time or different problems, there are different elevation or elevation of bilirubin. So in some cases there are conjugated bilirubinemia, or in some cases there is unconjugated bilirubinemia, or direct indirect you can also say. So direct one is conjugated, indirect one is unconjugated. So total it is 0.3 to 1 mg per dl. Also the other parameter, if you see in mgdl, and if you see in millimole, micromole, so it 5 to 17 or 20 per liter. Indirect, it is 0.1 to 0.3 mgdl. In micromole, it will be 1.5 to 5 micromole per liter. So in some countries milligram per dl is used, in some countries micromole. Indirect is 0.2 to 0.8 mgdl and 2.5 to 12 micromole per liter. Okay. So then next one is our ALP, which is alkaline phosphate. Phosphate is whatever you say. The you have like in Ukraine or Croc, you have some terms used very frequently. In Croc 2 questions also you will get that some syndromes like cytostatic syndrome, cholestatic syndrome, liver insufficiency. Okay, so we can know from these parameters. So ALP 40 to 120 in unit and 0.5 to 1.3 millimole per hour liter. Sorry. And last one is albumin. It's 3.4 to 5.4. Okay, so what problem we can suspect here? So if ALT, AST and total bilirubin get increased with cholesterol, so ALT, AST, bilirubin with cholesterol, and then we have direct bilirubin, ALP and cholesterol. I have a separate video in this, you can see that also. Here also I am just hinting much, not too much, just a little. So ALT, AST, total bilirubin plus cholesterol, ALT, AST, total bilirubin plus cholesterol, and here direct bilirubin, ALP and cholesterol. So what's called ALT, AST, total bilirubin and cholesterol, it is called cytolytic syndrome, and direct bilirubin, ALP and cholesterol, it is called cholestatic syndrome. And in liver insufficiency you will get all these things: decrease albumin, decrease cholesterol, decrease these things, decrease liver insufficiency. If albumin get decreased in blood, you suspect of kidney problem, because albumin doesn't excrete normally. So if it is excreting and you see proteinuria, you suspect kidney problem or liver problem also. So liver is not producing enough albumin. Next one is our urine test, and a pretty important one. So first one is bacteria. Normally we don't have any bacteria in our urine. Our urine is sterile when it is excreting. After that bacteria grows, but when it's excreting it's sterile. In our body urine is sterile. So if positive bacteria, then it's infection. So we suspect UTI. Okay, if we get any bacteria in our urine, we suspect UTI. Okay, then RBC, it is less than 5. So more than 5, it is called hematuria. So there can be lots of problem where hematuria can occur. Okay, so basically there's some problem when you have blood in urine, you see microhematuria or macrohematuria, whatever you see. Okay, so there is some problem. WBC less than 5. If it is less than 10, then it is pyuria. Again we suspect UTI. Then leukocyte esterase, it is absent normally, but if it is positive, again we suspect UTI, pyuria. So pyuria, if bacteria present, if WBC more than 10, if leukocyte esterase present, we suspect pyuria and UTI. Okay, UTI can be also cystitis also. So epithelial cell, it's also normally it's less than 5. So if it is less than 5, your urine is fine. Okay, there is no problem in it. Then pH, normally it is 4.5 to 8. If more than 8, So if urine gets more alkaline, then we suspect urea splitting organism like Proteus morabilis. Okay. Then next one, specific gravity. Specific gravity normally it is 1.005 to 1.030. So if specific gravity increases more than 1.030, what we suspect? We suspect it means the urine is concentrated. Okay, and in which condition urine can be concentrated? If there is, yes, dehydration. Okay, and if it is less than 1.005, we call it the urine is diluted. In what condition the urine can be diluted? So if you are drinking too much water, or there is some problem which you are getting thirst too much, like diabetes insipidus, polydipsia. Okay. Then color. What is the normal color of urine? Normal color of urine is pale yellow, and it is basically clear or slightly hazy, not too much, not cloudy. Okay, clear or slightly hazy. Clear to little hazy. Okay. Then next parameter is glucose. Normally glucose is absent in urine. If there is glucose present in urine, we call the patient is having diabetes, glucosuria, right? Then protein, normally not present. If it is present, then we have some problem with the filtration. So protein is getting filtered in nephron, so there is some problem in the nephrons filtration in your filtering membrane in your Bowman's capsule. Okay, so this is the chart. You all need to remember these things by heart for exams, for your clinical practice, all. And we left one thing, that is nitrate normally absent. If it is present, also bacteria. Okay, I think that's enough. Thank you. Take care.